A few minutes to jump on and get situated. We have an amazing presentation for you today. I'm so happy to be back. It seems like it's been a long time since I saw everybody. November, I guess it was. Hope everybody had a wonderful holiday. Starting 2024 out strong. I think you guys are going to really enjoy this. And let's see where we're at. We're at 79. Please do us a favor. Jump in the chats. Let us know that you're here. Say hi. Let us know where you're from. That's one of the best parts of this. So I'm going to go ahead and get started, and that way we can get to the good stuff. So again, welcome to the 2024 Professional Webinar Series. My name is Christy Weeks, and I am the Digital Media Manager and Brand Manager at Harmony Foundation. Let's see if I can get my technology to work. Today's presentation, the role of attachment, and I misspelled attachment. Please don't hold that against me. It is January. I have 11 more months to make up for that. The role of attachment in addiction and trauma disorders and treatment, presented by Dennis Bollinger. He's the clinical director at Momenta Recovery. So a little about Harmony, in case we have some new people, and I'm thinking that we do. We are, located on 43 acres in Estes Park, Colorado. We are near the Rocky Mountain National Park. It's beautiful. It's a great location. And we have over 54 years of treating addiction. And we are an abstinence-based program. As far as the programming available, we have a 70-bed residential program. We do have full medical detox. I have a virtual IOP. I believe we run 3 different sessions. So if you're interested in that, please reach out. And we have a family support and education program that provides an amazing amount of resources for our families, plus alumni support services. We have one of the stronger alumni-based programs across the country. So here we go. My clicker is off today, y'all have to forgive me. As we move on through here, we are individualized and gender specific in our treatment practice. We are evidence-based in a 12-step program, and we do provide a lifetime of support for alumni and our family members for free. So we provide meetings for them on a regular basis, plus events for our alumni and family members as well. So if you're interested and want to learn more about Harmony, please reach out. We're at harmonyfoundationinc.com or call 970-586-4491. That's our main number, and somebody would be happy to answer your questions. So with all that being said, there are a few things I need you to know. This webinar is being recorded and will be accessible on our website on Friday. I will include the link to our website in your certificate emails if you need to reach this presentation. We are offering 1 CEU. It will be emailed by the end of day on Friday. You must be involved in this presentation for 45 minutes. I do track that. So if you have to jump off early and you want a certificate of participation, I can provide that for you, just not the CEU. And then please complete the survey. Sometimes it pops up at the very end and you can catch it before you pop off. Please do that. It helps us guide our topics that we're going to present for the rest of the year. And we really like to hear your feedback and how impactful the information was for you. So do that. Also, I will include the link in the certificate email as well if you miss it at the end of the presentation. So our presenter today is Dennis Bollinger. He is the clinical director at Momenta Recovery. He has a very long, lengthy, thorough bio with a lot of fabulous information. I am not going to read it all to you. I'm going to let him give you the highlights and then let him take over because I don't want to take up too much of his time. But as I say that, I would like to say thank you to Momenta Recovery for donating their time today for this presentation. If you want to learn more about them, please go to their website at momentarecovery.com. And questions can be answered there, and I will be including contact information in those wonderful emails as well. So with all of that being said, I am going to turn this over to Dennis. Dennis, thank you for coming.
Thanks, Christy. Thanks for having us.
There you go.
So I appreciate this. I did do one presentation a couple of years ago, and so I'm happy to be back and thankful for you guys having me back again. Today I'm kind of going to jump into things because there's a lot of information to share, and I think we're going to scratch the surface on some of that information because there is so much to share in terms of attachment, trauma, and addiction. Today we're going to really focus mostly on attachment. And to give you a little background about myself, I started over 25 years ago working in substance abuse treatment. And during that time, began to become more invested and focused on trauma. And as I was moving through trauma, I started to take a position as the director for a center, and during that time actually got trained in infant mental health. And at that time I had no idea what I was doing with infants or about attachment or anything as it relates to that, but over that time started to really lean into understanding attachment typically as our first trauma, and then how often that linked to addictions. And so I think most people now have come to understand that, trauma is really correlated extremely highly with addictions. And I don't think there really is anybody that we serve at Momenta Recovery who doesn't struggle with the co-occurring nature of trauma and substance use. And so at Momenta, we really focus on three things, and that is trauma, attachment, and addiction. And so today I want to talk about attachment, and I have want to go over a little bit. Christy covered Momenta, so I won't spend too long on who we are, but we are an 11-bed residential treatment center for women that are struggling with addiction, trauma, and attachment disorders. And so we have that focus in terms of co-occurring treatment. We do have the continuum of care. So we start with a 90-day residential women specific treatment program. And then from there have sober living, IOP, and then outpatient services. And we can follow clients for at least a year. And part of that is the focus on attachment and the belief that we need to serve people over a continued period of time, and that moving from one clinician to another tends to cause some disruptions in the attachment that we're trying to correct that they experienced. At Momenta, our theoretical foundations really are first and foremost that as human beings, we're wired to connect and seek connection and love first and foremost. And that in the absence of those things, we'll seek alternative methods to get those needs met. We also believe that attachment wounds are adverse experiences that can lead to developmental trauma, and that traumas, especially developmental trauma, set the stage for addiction. And so in treatment, we need to be able to concurrently treat attachment wounds, trauma, and addiction. The learning objectives we'll cover today are how our attachment styles are established and how to identify and assess for an individual's attachment style, how utilizing an attachment-based therapeutic approach can improve treatment outcomes and engagement, and specific interventions that you can use as you leave here working with your clients today to utilize some of those attachment-based perspectives. So jumping into attachment, one of the people that I really like is Dr. Dean Ornish, who noted that anything that promotes feelings of love and intimacy is healing, and anything that promotes isolation, separation, loneliness, loss, hostility, anger, cynicism, depression, alienation, and related feelings often leads to suffering, disease, and premature death from all causes. And so that's something that we believe strongly. And I also believe in the connection highly between the mind and the body, and that there are many diseases that are exacerbated or caused from trauma. And so Another person that I really like, Oliver notes that the absence of a attuned connection betrays an existential promise woven into our human fabric. As we have seen, without these interactions or with abusive, traumatic, or neglectful interactions, a troubled future becomes more likely. And that troubled future is specific in terms of increased mental health and addiction problems. And so we consider, or at least I consider, and Momenta considers addiction as a result of an attachment disorder or a disrupted attachment. So addiction is not about pleasure seeking, it is about comfort and regulation. And so individuals might choose a substance as an attachment alternative to relationships. They seek out substance as a way to self soothe during times of distress. So we'll go more into that as we go along through the presentation. And I know I'm kind of running through it fast. So I just, sorry, get excited and like to share. But essentially, what happens is that as an infant, we learn that when there's disrupted attachment, we learn that we seek comfort and that we cannot depend on others. So sometimes when we seek out that comfort, either people aren't there or they're inconsistent or they don't know how to comfort us because their own attachment to their own parents was not as healthy as it should have been. And so we learn very early on that there's that absence. And what we know about adverse experiences is that we can move as human beings through potentially traumatic experiences or adverse experiences. As I refer to that, I'm most notably referring to like the adverse childhood experiences, those 10 questions, but there's a whole lineage of different traumas that people can experience. And we can work through those really pretty well if we have the comfort, security, and love of others to help us work through those experiences. But in the absence of those people, that becomes problematic because we learned that we can't rely on other people in order to move through those experiences. And so oftentimes what we do is we internalize those adverse experiences. We don't talk about them. We try to manage them on our own. And that leads to a lot of discomfort. And so then we seek out ways to cope with our feelings and lean into factors that promote a sense of comfort. And neurologically, comfort comes when the reward pathway is activated. So, food, sex, substances of abuse, and things like that become the new way we regulate our feelings and trauma. And then that winds up with the individual attaching themselves to the things that help them regulate their emotions and brings them comfort. Most notably, substances do that really well. So, jumping into our learning objectives, I think in order to be able to move into understanding attachment, we have to know John Bowlby, who's considered the father of attachment theory, and then even more well known as Mary Ainsworth, the mother of attachment theory. So, most of the things that I will talk about today really relate to the work that these two had done and then everyone that follows through. Um, so first and foremost, infant mental health starts in utero. So when I went through the training to begin with mental health, I first questioned, how do these little babies actually have mental health and how can we actually understand that? And there were lots of factors that I started to learn about just how complex infants are in the interactions between infants and their mom and then infants and other caregivers. And I do point out specifically, Mom, and as we go through this, you'll learn a little bit more about why that is. Um, but it is a unique and different connection than an infant or an individual will have with anybody else in their lifetime. So I started learning about infant mental health and learned that it really starts in utero. And we have to understand that when we think about attachment, because attachment does start really the last trimester of pregnancy through the first 2 years of life. And so there's really good research that has been done and replicated time and time again that shows that that is what is considered the critical period for the establishment of somebody's attachment style. But of course, the infant's mental health starts that process out and contributes to that part. So we need to understand that there are factors that impact an infant's mental health, which does include the mother's physical and mental health during pregnancy. So obviously, use of alcohol and other intoxicants during pregnancy or exposure to different toxins will do have an impact on the developing infant's mind as well as their psychology. And then we also understand that that stress within the mother tends to lead to infants that are more stressed and anxious. And that kind of continues throughout life due to some chemical changes and neurological changes. But also, we understand that an example of that is exposure to intimate partner violence. And intimate partner violence has been linked to a doubling of risk of preterm birth and low birth weight. Both of those factors impact an infant's attachment and development over time. So, infants that are born preterm and have to be removed from their mother in order to have life saving interventions don't have the same ability to attach to their mother because of contact and because of what's happening. And for many preterm infants, this is the beginning of a disrupted attachment. So we need to be highly aware of those things that increase the potential for attachment disruptions, because those are also linked to attentional, behavioral, and psychological disorders in children as well as in adulthood that I think follows people throughout their lives. Next, we have to know that is infants are wired to connect. One of the biggest things I learned during my training was that it's all about connecting, attachment, and being secure. Um, I know, like, one of the things when my own siblings had their children, as an uncle, I would always love like when you would hold an infant's hand and they would wrap their fingers around your finger and you just felt this sense of connection. Well, of course, during my training, I learned that that's nothing but an inborn response that actually allows the infant to pull you into their world and make you feel more connected and loved by them, which then helps with their safety. So, infants are really wired to stay safe, to keep themselves safe, because as human beings, we're more dependent for longer periods of time than any other animals. And in that, we're also wired to connect. So, some of the ways that infants connect to us and make us feel special and then create that connection is the wiring. So, infants do have that innate readiness to attach immediately. And part of that, like I said, is because we're dependent for so long to our caregivers. The other thing is pheromones and signature odors play a role in the attachment of infants to caregivers and vice versa. For example, I said in regards to moms, moms have a different type of connection that no other caregiver will ever have with the infant. And two of the main factors that go into that are oxytocin. And oxytocin is, we probably all know it as the love hormone, but it's also the hormone that stimulates uterine contractions and initiates breastfeeding. So the role of oxytocin between mother and infant is special. And then you have layered on top of that human mammary pheromone. So we have hormones, then we have the pheromones, and those are unique chemical signatures that infants take in. And then you layer on top of that signature odors. So signature odors are kind of micro molecules that combine with the hormones and the pheromones to create a smell that is unique only to the mother. And then that infant, in terms of kind of connecting to the mother or imprinting with the mother imprints to that smell. And then that infant knows this is my mother. And that actually can start a little bit in utero with the sharing of those hormones. And so mothers and infants have a connection because of these things that is different than anybody else's connection. It's why infants that are even adopted very early on, and from infancy will have kind of that primal wound is on a biological level. As an infant, they have imprinted into their mother, know her unique pheromones and hormones, as well as signature odors and the combination of those. And if that isn't present, they immediately sense that something is wrong. And that would be an attachment disruption early on with that infant. And so this can begin very early on. The other thing then is the attachment, it's called the attachment dance between infant and caregiver. And so the way infants seek out connection, the way parents respond to that connection, caregivers respond to that connection, and the back and forth begins to shape our developing brain. And it begins to shape our psycho-emotional systems, right? And so that will play into what we call our internal working model or schema. And that starts immediately. And so that's part of the attachment that we're talking about. And then infants are wired to expect attachment interactions, and without them, there's a lot of pain. And so, like, you can even see this in infants are born with mirror neurons, and mirror neurons are exactly like they sound. If somebody smiles at us, we smile back. If somebody's laughing, we might smile. If somebody's crying, we make a sad face. And you see parents and infants do this all the time, back and forth, back and forth. And it happens hundreds of times a day. And so these expectations are expected to be there. Without them, it becomes problematic, and the infant experiences significant pain and loss. This can come up normally through life, and infants aren't going to get all of their asks to a parent for attention responded to, but they have to have a certain percentage met. So sometimes this gets disrupted when we have a parent who might be going through postpartum depression and can't emotionally show up the way they might want with their child. Or if they are depressed and the child is experiencing happiness, but looks at the parent, and when the infant smiles and the parent doesn't respond to that, there's a disruption there. And that causes pain. The other thing I try to remind people about is we have to understand that when it comes to these interactions, people ask me all the time, how can they be that significant? Like, that was in infancy, it's not that big of a deal, or that was only for a day or two. One of the things I remind people is you have to remember infants have only been on the planet for a very short period of time. So in terms of perception, every moment to an infant seems much longer than it might seem as an adult. It's kind of, I call it like when I was in elementary school, I'd be staring at the clock, waiting for the bell to ring to get out of school so I could go play with my friends. And a minute or 5 minutes seemed like an eternity. And now as an adult, because my perception of time has changed with aging, it seems like it moves too fast. So we have to remember each moment to an infant, because they have had so few minutes on the planet, begin to be a big deal. So days are very, very long to newborns.
So Dennis, I have a couple of questions here.
Yeah.
So number one, this is terribly interesting to me because I am adopted.
Mm-hmm.
So that whole connection that you're talking about is just making a ton of sense for me right now. But first question is, Erica would like to know how that wired to connect work theory is with surrogates.
Yeah, so I think it becomes very complex because you'd also have to figure out genetically where things work. But would overall, the big thing would be the surrogate is actually the primary for the child. And so what will happen is similar to like you're saying in terms of an adoption, even though the parents are involved and these things are going on, the infant on a biological level is going to be connected to the person who is pregnant. And so
Right.
when they disconnect, there will be an actual attachment disruption. Um,
Yeah,
what you have
see,
to do
it,
later in life is try to mitigate those disruptions through relationship, but there is going to be a natural, it's kind of referred to as the primal wound. There is going to be a natural feeling that the infant experiences of my mom isn't here.
right, right. Yeah, 'cause like I was not held by my biological mom. She was afraid if she did, she wouldn't be able to continue with the adoption. So I feel
Right.
like that affects how you build your relationships later on, possibly with your own family, um, in that sense. One more real quick. Are preemies hurt by the incubator attachment process? Is it
Yes.
applicable there?
Yes, absolutely. They don't, I mean, they're in the incubator and we have to think about, right, imprinting, right? And there's a whole Ariadne's thread around this and things like that. But when you think about imprinting, it's similar process, but babies do it more olfactory than any other way. And so very early on, the olfactory senses and the pheromone exchanges don't take place. And so there's a disruption there. And I know hospitals have done a much better job in understanding this and trying to do more physical contact with mothers and parents and do more of that so that they can get more of this connection. But it's olfactory, it's not just touch. And so when they're in the incubator, you lose the olfactory response, which then again, if you think about time, even though the infant's in the incubator for maybe a week, to them, that's their entire life. And so it's not a week, it's a lifetime, right? And
Right.
so that all of a sudden their brain is saying, my parent, my mom especially, is not here for my lifetime, right? And so that's where that gets set in pretty quick of I feel abandoned. And of course, this is on a very, body sensation level.
Mhm.
And it's hard for people to talk about this and working through the traumatic aspects of it because it is so bodily oriented, but that's where some somatic work can be really helpful.
Okay, thank you. I'll let you.
Okay, thank you. So, and the other thing to note about mental health is in the first 3 years, children need to learn these skills, how to manage and express emotions, how to establish close, secure relationships with people, explore and gain knowledge about their environment, family, community, culture. And these all play the critical role in the development of an individual's personality as well as their internal working model, which I'll touch on in a minute. If these all get impacted, the one thing that can impact all of them immediately is attachment. If you don't know how to establish close, secure relationships, the rest of the things begin to be impacted. And if a parent is depressed or say they're using substances, they often don't teach the child how to understand their own emotions or how to express them in a healthy way. And that has a multi-generational transmission factor as well, because parents that didn't learn emotions well themselves don't do a good job teaching that to their children, and so on and so on. And so in therapy, we often get people with attachment wounds who actually don't understand emotions really well because they weren't taught them. And so in addiction, I find that this is huge. And part of the reason people lean into addiction is that they were really never taught what emotion they were experiencing and then how to manage it. And so they can't even classify their emotions. So one of the things we might have to start doing in treatment is just helping people identify what emotion it is that they're feeling, because emotions are socially constructed, right? We teach children what emotions they're having. If they're stomping their feet, we might say, wow, you seem really angry right now, or you seem frustrated. But if a parent doesn't like to talk about those feelings, they might try to just make things better rather than validating and letting the child know they're feeling. They might just tell them, stop stomping. Right now, the child isn't learning what emotion that is, how to express it, and then how to manage it. And so, those we see all the time in terms of mental health and addiction is people just simply don't even really understand their emotions, and we have to help them begin there even though they're 35, 45 years old. um, so going more into attachment, it really is the strong emotional bond that infants form with caregivers. We can boil it down to that. And so the healthy attachment comes from attuned parenting, which equips us for resilient success, emotional, psychological, and physiological well being. And I'm jumping through these just because I want to get to some of the interventions too. But the attachment gets established through early experiences between infants and parents. And these are two-way interactions. And without them, attachment gets disrupted. So when I was assessing children for kind of attachment and parental issues, things like that, like I remember having lunch and I was staring out the window watching a dad with his infant, and he was a very successful business guy, but he was holding his infant, and the entire time he was scrolling through his phone, didn't look at the infant once, and the infant was doing different things to try and get dad's attention, but wasn't receiving it back. And so that those little experiences can start to create, if they happen too much, they can start to create a lot of unattuned attachment or attachment disruptions. So the other way, the big way that it's formed and what children really need in terms of things is what has been referred to as the circle of security. And so children need their parents to be a secure base, which means that they keep them safe, right? They're safe, they're consistent, they're supportive. And then they need them to be a safe haven. I can come to you, and when I come to you, you comfort me, you delight in me, which we'll talk about. And you protect my emotional feelings. So kind of some of that is how children feel protected both physically as well as emotionally. And one of the things that is a highlight there is parents need to be bigger, stronger, wiser, and kind. Those are the biggest things that I think I learned parents always need to hold, because children shouldn't actually be the ones teaching parents anything, or they shouldn't be directing the parents, because the world is way too scary to a little kiddo. And so they need somebody that is going to protect them and keep them safe. And then over time, allow them more of that power in the world. And then you want to follow your child's need and, when necessary, to take charge. So what attunement is, and all of these things will relate to how we should engage with somebody in treatment. But attunement is the ability to be aware of, emotionally in sync with, and appropriately responsive to one another. So essentially, attunement is, can I identify what feeling you're feeling? And can I validate that feeling in you? So in children, what we often do is we see them display their feeling, and then we respond to that feeling like, oh, I notice you're really happy, or you're smiling right now. You must be joyful, right? So we start to teach them those feelings, and we're in tune. But sometimes a parent is not in tune. And if they're not great with their own feelings, they may tell a child, oh, you're really happy right now. But if the child isn't happy right now, that's where the discrepancy takes place. And that discrepancy then causes an attachment disruption or an attachment little problem there. And if that happens too much, what the child begins to learn is, my parent doesn't understand me. My parent doesn't know what's going on with me, and I'm not connected to them, and therefore I don't feel safe and comfortable with them. And so the way I kind of have noticed this mostly is in some parents, when I was working with them in infants, an infant could cry, but to me, not being a parent, their parent with them all the time, a cry was a cry. To that parent, they could distinguish the cry of hunger versus cry of pain, and they would respond very differently, or even a cry of, I need my diaper changed. Parents would know and be able to distinguish those. There were some parents that we noticed that couldn't do that and probably didn't have that from their own parents, but they struggled to be in tune with them. So, as therapists, and we'll talk about this later, we have to be attuned to our client. If we're off, we need to make those adjustments and get accurate. Otherwise, they're going to feel disconnected from us and that we don't understand what they're going through. Next thing is mirroring and attachment. Like we mentioned, there are mirror neurons. We know about mirror neurons. And what they really do is they allow us to just basically mirror back interactions. And you see this in mothers and infants, fathers and infants, caregivers and infants. When the infant displays an emotion on their face, the parent gives it back to them. And so, in this, I picked this picture because the first visual distance that infants have are roughly 12 inches, which is basically the distance between breastfeeding and mom's eyes. And so the first thing they're even wired to begin to notice is facial features and what's going on. And so those allow us then to attach when we mirror back to the infant the emotion that they're displaying. Delight in is the process in which infants feel that their parent just simply likes them for their existence, right? So it's the ability to take great pleasure in just the existence of our children, to be very happy because of something or someone, or finding a high degree of satisfaction or joy just being in the presence of the other person. And so that's really the delight in. Now, you can imagine if a parent is extremely depressed or struggling with addiction, it becomes very difficult to delight in the child. And so that can also lead to disruptions. So, if most of the time our parents are attuned, mirroring, and delighting in us and meeting the majority of our needs, and infants ask for way more needs than we could ever meet, and it would probably be problematic to meet all their needs. Um, if that happens, we end up developing a secure attachment. And so the way that's easiest to identify people's attachments, we'll go through them quick. There's assessments that you can do, but the easiest way I feel is from this chart. 65% of our population is roughly secure, right? So these are people that are comfortable with themselves and others. So they have a good view of themselves and they have a good view of other people. They're also very good with emotional closeness and emotional distance, as well as physical closeness and physical distance. And so these people don't seem to be moved by much in relationships in terms of becoming extremely emotionally reactive to things that happen in relationships, because at the end of the day, they have a feeling of this person will be here. They're consistent, they're dependable, they're stable, they're good, I'm good, everything's okay, right? And that also connects to their internal working model, which we'll talk about. If there's too many disruptions, what we end up finding is people fall into insecure attachment styles. And so this is a little bit different than attachment disorders, which we're not really talking about today, but are styles. The addict or the anxious attachment, and more addict is not necessarily the addict of substance use addict, although lots of substance users are anxiously attached. Typically, they're characterized, you can identify them because they have a really good view of everybody else, but a very negative view of themselves. They do not like distance from other people. They're very insecure in that way. So that's kind of the addicted part. Like, I need to be close to you. I need to be connected to you. I must have you around. Otherwise, I'm not okay. And so this is where codependent people often fall into this category. It's also where stalkers and abusers and those people fall into typically is into this category is because I'm not good and everybody else is better, they're going to figure that out and they're going to leave me. So I must hold on to them tightly. That would be when I work with people, the easiest way to identify somebody who's anxious. And then there's the avoidant. And avoidant are people that have a negative view of others, but a positive view of themselves. And so what this leads to is I actually don't want people around me. I will avoid them. I don't need them. I don't need connection. I don't like a lot of people. And the reason for that is I'm okay, but you're not. You're just going to make my life worse. And so I'm just going to be over here by myself. And that's where I find myself most comfortable. And then you get into anxious avoidant, which is ambivalent. And it depends on kind of the attachment theorists that you listen to or trained by, how to use those words differently, or disorganized has a little different flair as well. But ambivalent or anxious avoidant just means there's a combination of the two. And so they just kind of go back and forth. What I would say is that momenta, most of the time, we do not believe in borderline personality disorder. What I would say is you have somebody that's ambivalent in their attachment style. They do really well when that relationship isn't at risk of being lost or they don't perceive abandonment. As soon as they perceive abandonment, now their reactive part comes in and they push you away. And that's where you start to get this push pull where they'll either push you away or they'll pull away. But really underneath, they want to be close, but they feel that potential rejection. And so they respond to that in either a push or pull dynamic. So that's where I would believe that borderline personality more is in line with trauma and trauma specific to attachment. With all of these things that happen, what we then do is we create the way that we see the world. And so with our attachment to others, how they showed up, how I interacted with them, my early experiences, now I create the way I see the world and I react and interact with people in the world based on how I see it. And so if you develop a healthy internal working model and you had a secure attachment, this is the Bernstein Bears, which I love, you actually end up forming this view of the world that people are pretty good. They're happy. The world is safe. It's colorful. Things are nice. But if you had disrupted attachments for some reason, and then even worse, you layer on top of that other types of traumas, you begin to see the world this way. And you begin to interact in the world in a way that you see it, right? So if I see the world like this, and it's scary, people are up to stuff, people are going to take advantage of me. If I go through an experience that is adverse and I need to talk to somebody about it, right? Because talking about adverse experiences is what prevents them from moving into traumas. If I do that, I'm good. But in this world, I don't trust any of these people. None of these people look safe to me to talk to about what just happened. So now what ends up happening is I end up internalizing that, creating the trauma and the trauma symptoms that go with it. And so now I have just become more traumatized because the way I see the world is not safe. And then that trauma reinforced, oh, the world's not safe and there's nobody you could go to. So then I'm more likely to be traumatized again and again and again. And that's where our clients come to us and they have relationship difficulties. And we're like, why do you keep getting into these same sort of relationships? Well, part of the idea is this is just the way relationships are. This is my expectation of the world. I expect it to be this way, not this way. And so I continue to replay these relationships because of the impact of my internal working model or my schema. And so then that creates more and more trauma. And then in adolescence, somebody at school introduces you to alcohol or weed and you take it, and all of a sudden the world looks like this. Now we have just set the stage for why people become addicted. I'm going to spend my time here and not here. So we have to understand that when we're working with people and doing this work, is that this is what we're actually taking from them when we want to take their substances. This is why people do not want to stop using, because they would revert back to this. This is early recovery, right? And this is with substances. So even though bad things happen, we have to understand why they continue to use and do the things they do and how that's connected to our internal working model, which is based on our attachment. And so our goal is eventually we want to help clients get to this place without the substances, but they have to go through this, and we have to sit with them in this place in order to do that, right? So therapeutically, the first thing we need to understand in order to help people is this is how they see us as therapists. They do not see us as these good, sweet, nice people. Many of them come in seeing us as we've got an agenda, right? And that's why sometimes clients will just say, well, you're just paid to do this, right? And so that's why we have to show up in a way that utilizes attachment strategies to build a therapeutic relationship, because we have to change the way that they see relationships. So the first thing we have to do is delight in our clients, right? If we're angry, we're upset with them, all these sorts of things, if we let that show too much before we build that relationship, they're immediately going to see us like the rest of the world, and they're not going to engage with us. So as a therapist, when I'm meeting people in the beginning, especially, I call it kind of my puppy dog syndrome. I am so happy to see them. Like when my dog greets me at the door when I get home from work at night, like just my existence makes their world light up. And with clients, we have to engage them in the same way. When we start utilizing that and start doing, being excited that they've come to see us, letting them know, hey, like I was thinking about you and I'm so happy to see you today and I'm glad you came. And it feels like it's been a long time since I got a chance to sit with you and I'm excited to sit with you. When we start to delight in people, all of a sudden they want to be in our presence, right? It's like I want to be in my dog's presence. They want me in their presence. Like that's the first thing I do at night when I get home is we greet, and it makes me feel like my whole day washed away, right? If we can give that same feeling to people who are often marginalized and put down, and where their own families and people are angry at them and don't want to see them, we begin to create an engagement that's extremely different in their world and can start to change the way they see the world. The other thing we can do is mirroring. So neuro-linguistic programming talked a lot about mirroring and the effects of it. So if you can think about neuro-linguistic programming and different things that you do, even with body movement, in your sessions, you should be literally mirroring your client on every physical and verbal level that's possible, right? So you sit how they sit, you kind of move how they move. You literally are mirroring them, and they don't know what you're doing, but what you're doing is you're connecting with that pathway in their brain that makes them attached to you, right? And then if you use the language they use, because I work in addictions, I swear far more than I probably should, but that's because I use the language, right? So if the clients use certain language and certain words and phrases, we want to mirror that and do the same thing, because that makes them feel connected and attached to you. And if you're connected and attached, you're going to help me do what I need to do. And to delve more into mirroring, you can do a lot with NLP. I really am a big fan. I'm a big fan of hypnosis, and NLP are kind of together. But if you really want to look at all the different ways that you can mirror, jumping into that is an excellent way to be able to do that and using those skills. But again, it kind of takes you back to grad school of what are the basic engagement skills that we use with clients. And a lot of them is to mirror our clients. So that becomes essential. And then you can test to see how attached they are, to see if they start mirroring you. If you change your rate of speech, if you change the tone, or if you get quiet. I get complained at all the time because I almost whisper, and I see if people whisper with me, right? that lets me know that we are attached and that we're currently attuned to one another, right? So those are the things that help us. And then this of most important to anything is attunement. So what is the difference in the baby on the left and the baby on the right? Pretty easy to see the baby in the middle and kind of think about, okay, what's going on for that little kiddo? But the left and right, right? When I looked for images for this, they actually came up differently. One, the baby on the left is actually baby crying. The image on the right is baby yawning, which actually makes sense to me. Having done infant mental health, there's a little bit of a difference there in the mouth and the face. But those unique, subtle differences is what we have to attune to. So sometimes in therapy, we will say to a client, oh, that must make you really angry. And they'll say to us, no, that doesn't make me angry. That makes me frustrated. What they're doing is asking, will you attune to the way I feel? And if you don't go, oh, frustrated, right? Now you're not attuned to them. If you say, no, 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 you're really angry, right? I can tell you're angry. You are now no longer attuning to them. And what you're telling them is your feelings are wrong and we're invalidating them, right? Which often leads to lots of problems. And so when clients give us feedback, we want to just think of it, I think of it as like we're throwing darts at a dartboard trying to hit a bullseye. And if I say to a client, oh, you're really happy, and they go, no, I'm pretty joyful, but not happy. I listen to that as they're telling me, hey, here's how you hit the bullseye. And they do that in a lot of different scenarios. And sometimes I think as therapists, we're like, well, I know better. I know you're really angry under there. But if they're giving you a little bit different word, you need to explore that. Ask them more about that. Want to understand that. Use that therapeutic wonderment to attune to what they're actually trying to convey to us because we're slightly off. And that's what the little kiddo in the middle makes me think is I actually am not sure what's going on in their head. Are they seeking connection? Are they wanting to share their toy with me? Are they wondering, am I safe? Am I not safe? Right. And so with adults and with language, we can get more into understanding just the simple differences in emotions. And when we take time to slow down and really piece apart different emotions for people, they attach to us far better. And so things just to think about, and I will share this slide deck so you can get this, but what you want to think about as it comes to implications for the work that you're doing is first and foremost, what is my own internal working model? How do I see the world? How do I see my clients? How do I see coworkers? How do I see parents? How do I see all these people? Because that's where you get into all the transference, countertransference, all that kind of stuff. But our internal working models and the way we see the world, right, will influence the way we see our clients. And then our clients, we put things onto them based on the way we see the world. And then we have to try and understand how they see the world. So basically, we have our own glasses on. We see them, we interpret what they tell us through our own lens, and then we have to make sense of it all, right? And so it's a very complex process. And if we don't understand the way we see the world, we are off all the time in being able to attune. We need to understand, how do I see the world? How do I see my clients? How do I see this client in particular? How do I feel and see and think about the behaviors that they're presenting with? And then that goes into, okay, so how did my own attachment style impact those things and those interventions? So I'm very aware I have a pretty anxious attachment style. I manage it pretty well. But that impacts my interactions with clients, and it also impacts my clinical decision making. And so I try to ask a lot of the time for feedback from other people and what do you think and what do you think? And that's why teams work so well, is they can help us challenge us on what we're thinking and maybe how our own style is impacting the work that we do. And then um, we have to account for the difference in the perception of ourself versus the client's perception of us. Remember, as therapists, as helpers, we often view ourselves as very caring, kind people. And we often expect our clients to feel the same way about us. And the reality is that has not been their experience in the world. If they're coming in for treatment, almost most of the time, I feel like, yeah, you don't really have a secure attachment style. The final thing that I'll leave you with too, in terms of secure attachment style, all the time people will say, I'm secure, I'm secure, I'm secure. And if you look up Ainsworth's work in terms of the stranger experiment, the way we understand what our attachment style is only when there is stress in a relationship. When relationships are good, relationships are good. We're all securely attached. The only time that insecure attachments really show themselves is when the relationship is under stress. So we always have to assess for a person's attachment style in relation to relationships when they were under times of stress. Again, remember, we all look secure when the relationship is good. It's only when there's perceived abandonment or insecurity in the relationship that the other styles actually show up. And so I'll leave you guys with that. And at Momenta, we always believe to lead with love. I know this goes against probably every professor that ever trained me and most of my supervisors. But, here and myself, I tell clients I love them. We talk about what that means to have a loving relationship because people often get that confused when we've had difficult relationships. But love, in my opinion, needs to be a central part of the therapeutic process. But what has happened is we took it out of the therapeutic process, the healing process, because of fear around lawsuits and things like that. My feeling is, and what we believe here is it is an essential piece to the therapeutic process and to the healing process, which ties back to, if you look at the first slide we started with, that is actually the thing that heals people. And so that must be a part of the therapeutic process. And if anyone ever wants to talk more about it, it's something I really enjoy talking about and would be happy to talk with anyone about. Now, any questions with 2 minutes? Sorry.
Wow, Dennis, my whole feed, the whole chat box just blew up with how amazing this presentation was. And we're so grateful because there was so much information so well presented. Um, you've been requested to come back multiple times. So I think I do have one
Well,
question.
I'd be happy to do that.
Yay. I already
Yeah.
I'm sending dates. Um, somebody did ask if this applies to eating disorders.
Yes, absolutely. It applies to addictions and process addictions. Most of the time, or not most of the time, some of the time, um, our our eating disorders are actually our first addictions, right? It's not the substance. It is the eating. And food is one of the things that activates the reward pathway. So sex, food, substance of abuse, and adrenaline all activate the reward pathway, and all things that are potentially addictive activate the reward pathway. And so we find co-regulation or attachment in those things as well.
Thank you. Everybody who attended, thank you so much for coming today. We are grateful for you and for you taking the time out of your day. Dennis, I can't tell you how helpful this was, and it was fascinating to me. I'd heard a little bit about attachment and being adopted, and again, having those, and then coming out of a foster home into a new
Mm,
home. There were several breaks that went
yes.
on, and my kids wonder why I keep them like all grouped up together so I know where they are all the time. But it was very helpful to me personally. Our audience enjoyed it, and we look forward to you coming back. Everybody, details on next month's webinar will be coming out soon. Stay tuned. This is available on our website starting Friday, so come back and take a look. We'll see everybody next month. Thank you.
Thanks.